The next case is a 70-year-old female patient with a history of chronic back pain and weight loss. CT scan showed a pancreatic and peritoneal lesion suggesting of adenocarcinoma and peritoneal spread. The patient was referred to us to undergo FNA of that lesion. This is the CT scan showing a 3.7 centimeter lesion, and Professor Haas is now going to show you the EUS and FNA of the lesion.
Okay, well, welcome again. I think this is the first time to be able to show the linear echoendoscope. I have the therapeutic, the UCT 180 linear scope, and we're using it with the Aloka Alpha 10 ultrasound processing system. So, as many of you know, I try to teach a very organized approach to using either the radial or the linear array echoendoscope. And I want to try to review for you the anatomy using the linear scope. And so I've begun, if you have the endoscopic image, you can see that I'm beginning the examination at the GE junction. So there is the squamocolumnar junction. Please? So there's the squamocolumnar junction. And so now I turn my attention from the endoscopic to the ultrasound image. So if you can have an enlarged ultrasound image, that would be best. And then what I do is I just torque the scope clockwise until I find the aorta. So here is the aorta. And it doesn't really require flow or anything like that to prove it, but that is the aorta there. Now, what I also like to have you do is to keep an eye on the crura of the diaphragm. And the reason I like to emphasize that is because when the crura disappears, then the celiac artery will take off almost immediately. And sometimes if the celiac artery takes off of the side of the aorta, if you're not cognizant of where it comes off, you'll miss it. So I'm just going to advance the scope. I'm torquing a little bit left and right. I think you can see the crura ends about here. And then right in this area here, you will see the celiac artery take off. So here is the celiac artery here. I'm going to push in just a little bit. And then here is the SMA down here. So SMA and celiac. And then what I do is I follow the celiac artery until it bifurcates. And after it bifurcates, I do big dial away from me just a little bit. And then that should find you the pancreas. So we'll just try to do that. This is going to be made a little bit complex by the fact that there's a mass now around this area, the celiac. You can see here this hypoechoic area here. And it seems to be surrounding the celiac. And so this is a little bit of an unusual situation. But let me proceed with the examination. We'll come back to that in just a moment. But here I'm following the celiac. There's the bifurcation. Tip down just a little bit, and then go back and forth. And you generally find the pancreas, which is in this area here. So this is probably the confluence. So pancreas above the confluence. And then a leftward torque generally gives you the genu. And a rightward torque sends you toward the body and tail. So here I'm torquing a little bit clockwise, and I'm just going to try to follow the pancreas here. It's a little bit inhomogeneous and a little bit difficult to follow. So that's why it's important that you sort of take this station technique. So here's the pancreas here. You can see a little bit of ductal structure running through the pancreas here. Here is the kidney down here. This is pancreas up here. Here is probably the adrenal gland between the kidney and the aorta over here. And then we get back to the aorta. If you find the celiac artery and you just torque clockwise off of the celiac artery, that's generally how you find the tail of the pancreas and the spleen. Here I think is the spleen in here. So again, that's the general review of pancreatic anatomy, and I'll just quickly review that one more time. So push in. Here's the crura of the diaphragm, celiac artery. Push in beyond the celiac artery, tip down, and then you find the pancreas. There's the genu, exactly. Bertrand has come in and helping me now. There's the pancreas there. Probably with pancreatic duct there. Continue to torque right. We continue to see the pancreas. And then here's the splenic artery, splenic vein coming together to go into the spleen. Push in just a little bit, and there's the kidney down at the bottom with pancreas just above it. So that's the general imaging of the pancreas, at least the body and tail. If you can go to the endoscopic image briefly. I'm now going to just take a brief survey of the pancreas in the head. So I'm going to advance the scope just like it would any other scope. I look for the pylorus in the foreground. Advance the scope through the pylorus. Big dial away from me so I can see where the apex is. I push in to get to the apex. In this case, I'm going to inflate the balloon a little bit. Come up on my up down and aspirate air. And then what I'm really looking for is the portal vein. That's what we see in the area of the apex. And then with that we have pancreas just to the right there. You want to do pulse?
No, I want to remove that.
I just go back. So Bertrand has put a line down the middle, which we didn't want, but that's okay. So here's the pancreas, the head of the pancreas here. And again, it's a lobular, and she's probably a little bit unusual for her age. Here's some lymph nodes. Some lymph nodes around the bile duct here. Around the bile duct and around the pancreas. That's probably bile duct right here. And we follow that down to the duodenal wall here. So it's sort of a lobular head of the pancreas. That's a little bit abnormal there, isn't it? So I think this area there is a little bit bothersome to me, Mike.
Rob, to me, one of the interesting parts of this case is that there appears to be a tumor that is wrapped around the celiac artery, almost as if the tumor is invading along the vascular sheath. We've seen this pattern a few times, and it seems to be a small tumor, but it extends along a vascular sheath. And I don't know if you've seen this pattern before, and if so, would you feel comfortable biopsying along the celiac artery where the most prominent abnormality is located?
Yeah, so I don't know how much time I have, Mike, and that's a brilliant comment. And to be honest with you, I'm sort of doing some thinking here as I go. Thomas was in the room here a minute ago because this is unusual, and I think is worthy of some discussion. This was clearly seen on cross-sectional imaging. As I traced the pancreas, though, I really didn't feel like there was anything emanating from the pancreas. But here you can see clearly there's a mass around the sort of, as you say, completely encasing the splenic artery and right actually at the bifurcation, isn't it, Bertrand?
Yeah, show there is thickening, which is
Yeah.
to infiltration. And if there is a tumor?
I don't know. So, Mike, is that inflammation? Is it a tumor? Is it a pancreatic process? Is it, you know, I think it's an interesting question.
I think this is tumor. We've seen this pattern before, and the pattern here is, again, it's a small tumor. It's a very subtle one, and I think you showed it nicely, probably in the inferior part of the pancreatic head when you were imaging from the bulb. But I think this tumor has escaped the pancreas and is likely tracking along the vascular sheath of the celiac artery and the splenic bifurcation.
Yeah.
We have a question from the audience.
Rob, I'm Dong-Wan Seo from Korea. Beautiful live demonstration, but I think in this case there is clear encasement of celiac axis. That is actually one of the common findings of pancreatic cancer, ductal adenocarcinoma. And for me, it looks like the head is abnormal. When you go into the duodenal second position, the heterogeneity of head lesion, I think that area is quite suspicious. And when you remember the CT finding of this patient, there is clear low attenuation area, enlarged area in the pancreas head and around the celiac axis. Did you have any enhanced CT scan here? Because CT finding will give better image, I think.
Yeah. I only have the static images that were presented in the case, Dong-Wan. I didn't have anything more. So, but I think you're right, Mike and Dong-Wan. I think everybody. My guess is that this is something that's tracking along the artery and probably emanating from the head. That lesion in the head wasn't reported on, at least on the CT. But you can see very impressive halo around the celiac artery. Excuse me.
We have two jobs as endosonographers here. We need to get a tissue diagnosis from something. We could biopsy the pancreatic head. We could very carefully do a needle aspirate of this tumor around the sheath. Lymph nodes are another possibility, and I often look very carefully at the liver. I don't know if we have time in this case, but liver lesions are sometimes the easiest to biopsy when present. One other job we have as endosonographers, this patient has back pain, and clearly, or at least what appears to be unresectable disease. So, Rob, would you consider a celiac neurolysis in such a case?
Yeah, so Mike, you know the issues of that very, very well. The only problem, I think she does have back pain, and I think that's a bad prognostic sign. And she may very well benefit from a celiac neurolysis. I just find it difficult to talk to a patient about doing a neurolysis unless I sort of know exactly what's going on. And so, but she may well benefit from that. I think what I'm going to do is I'm going to biopsy the head lesion here first, Mike. And I think that's the most accessible. I think, again, we talked about a little bit earlier, to get a good sample, you need to move the needle within the lesion. And I think getting the needle moving within the lesion around the celiac artery, I think may be a little bit difficult. But we can try that if nothing pans out with the mass in the head of the pancreas. But I'm pretty sure that there's a mass in the head. Your point is also very well taken. If you've got something that's invading the celiac artery, sort of invading along the arterial sheath, you've got a mass in the head of the pancreas. If you've got a lesion in the liver, they're the easiest by far to get good cytology from. And so I think it was a wise piece of advice to ask me to look at the liver before we go any further. I don't see anything. A systematic review of the liver requires looking at it from the antrum, looking at it from the duodenum, and then looking at it just as you torque right after the celiac artery takes off, or rather torque left counterclockwise. So those are the stations for the liver. And I haven't sort of systematically done that, but I don't see anything in the liver, and nothing was reported on the CT scan. So I think if it's okay, Mike, what I think I'm going to do, at least start out with, obviously it doesn't inhibit me from doing something later on, is go for for the pancreatic head. Would anybody do anything significantly differently? Here, I think to me, there's something going on here. And I think I have the agreement from Bertrand, so that's sort of all I need. So life used to be simple, Mike. Used to be very, very simple. The only needle that we ever used was a 22 gauge needle, and we just aspirated with a suction syringe, and we put the slide on we put the specimen on a slide, and we asked the cytopathologist to take a look at it. And now things have become very, 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 very complex. And do we use a 25 gauge needle to a 22 gauge needle? Do we use a 19 gauge needle? Do we aspirate? Do we not aspirate? Do we use a stylet? Do we not use a stylet? Do we have a needle with a side hole or a needle without a side hole? Do we use a wicking technique with a stylet, or do we do nothing? It's all very confusing for me. And the data is still coming out. But I think what I've chosen to do is use the Olympus needle. It's a 22 gauge needle that has a side hole in it. And I'm going to use the wicking technique on the stylet, sort of slow removal of the stylet as the initial approach. And then we'll see what that yields, and we'll make changes from there.
So we have a question from the audience while you're getting set up for your FNA, Rob.
Okay.
Right microphone on, please.
Wouldn't it be useful to use some contrast in this case?
Yeah. So Bertrand is the best one to answer that. Should we introduce contrast? Oh, you don't have a microphone, do you? So would contrast be helpful here, Bertrand?
Yeah, I think so.
Okay. So Bertrand thinks that it would be?
Rob, if I add a few comments on that, I think if we do contrast-enhanced EUS on this case, if it is a pancreatic adenocarcinoma, then it will not show any strong enhancement. I think there are a couple of experts on this area. And if it is inflammatory process, it will show diffuse enhancement. So I think it can be helpful for the differential diagnosis. But anyway, we need to get some sample to get the definite histology.
I think the issue at hand is to get a biopsy. I know we'll be hearing a lot about the different needles from Professor Ginez later on in the course, and also about echo enhancement from Dr. El-Abadi later in the course. So we'll focus on today's case of the FNA and how Rob's going to perform that.
Right, I think it's good discussion, Mike, and I think contrast agents do have a future. I personally not sure that they're ever going to be a substitute for histology, which is my main issue. But anyway, so we're going to get started, Mike, and you'll see the needle come out here. And I do believe in what I call the fanning technique. So what I will attempt to do is put the needle back and forth in this direction, then try to move it and get a different trajectory, so that I'm not going through the exact same point within the tumor. I think it's worthwhile to put the Doppler flow on, just to make sure that we haven't missed any large vessels. So now I'm going to start with the needle coming out. I think I'll have Bertrand point to where the needle is. So there's the needle. I'm going to use a little bit of elevator now. And you can see here that I have to go through some normal tissue here to get to my to get to my lesion. I like to indent, and then I like to thrust it. So it's not just a very soft kind of a movement. It's really thrusting. So now I'm going to ask, I don't know if the cameraman can show you, but we're just going to slowly withdraw the stylet. I call this the wicking technique. So we're just going to slowly withdraw the stylet as I go back and forth. Slowly. So there's the needle going to the back. Now I'm going to withdraw it. Now I'm going to go down to my up-down just a little bit to try to get a different trajectory. Then put the needle in. It's a very firm lesion, Mike. So now I'm going to withdraw it again. Try to go down just a little bit more. Adjust left and right. Then stab it in. Push the scope in a little bit. Torque. Always keep that needle in view. Okay, so that's toward the back of that. Slowly withdraw. Okay, and the stylet is completely out now. Now we'll hook up just a little bit of suction. Again, the sample is a dynamic, or sampling is dynamic. Okay, there I fell out of the lesion altogether. So I think we'll stop and take a look at what we have. What I mean by it being dynamic is that maybe I've got a good specimen in this situation, maybe I don't. So we'll look at the specimen and see what it looks like. And if I'm extra bloody, then I'll change my technique for the second round. If there's no cells and no tissue at all, then I may be more aggressive the next time with longer back and forth, maybe suction, etc. And whereas we used to do only quick preps on the slides, we're now doing cell blocks on every case. We're going after histology in many cases, and so the preparation of the specimen has changed a little bit. For Thomas, they currently have a protocol going between standard needles and the Procore needle, and so they may be doing something relative to their study in terms of the preparation of the material. Do you express it with a stylet, or do you push it out with a syringe? Do you push it out with some saline? Do you put it in formalin first?
Material inside.
Okay.
We saw it.
You saw it?
Yeah.
Okay. So I don't know if you can see this. This is the specimen for cell block. There was obvious tissue in the specimen, according to Bertrand. And so maybe we have the diagnosis.
We have a question from the audience.
Marcin Polkowski. Rob, what is the idea behind removing the stylet slowly during the puncture? Because at the end of the procedure, you anyway apply suction.
Right. So I would not have normally applied suction. It was offered, and I went ahead and did it. But the idea of the wicking, I think, it's an intermediate step between no suction at all and sucking with a syringe. And if you've ever felt it, we have a technician at my hospital now that actually can feel the slight suction pressure that pulling the stylet back creates. So I think it's this, the key to cytology. If an ideal cytologic specimen has no blood and has nothing but tissue cells in it for a diagnosis, and it's always that ratio of blood to malignant tissue that you're looking at least for the quick preparation in the room. And I think that just removing the stylet slowly produces a minimal amount of suction and therefore maybe less blood. I think we're still just experimenting around with it. I'm not sure that we have the perfect technique that fits every single case. Okay. So I think Thomas and his team, are evaluating that specimen, and in the meantime, I'm going to do another one.
Bob, I just wanted to add to the point, particularly for the new endosonographers, it's very helpful, if you can, to have a cytologist present in your laboratory to give you that immediate feedback if you're getting a good cytologic sample. It's critical that we get a diagnosis in EUS. That's one of our main roles. And to have the cytologist present to say that you have a good sample has been shown many times now that it improves your diagnostic accuracy.
Michael, I have a comment. Michael, in the microphone.
One question from the audience here.
Yeah, I would like to make a comment that in this, if you see the lesion, you can see that the lesion has white and darker spots. Normally, adenocarcinomas are like this. In our experience, we have a cytopathologist in the room, and we have been aiming the white spots on the black spots. And definitely, when you go directly into the black spots, you get less blood and you get more cells. If you go into the white spots, then you get more blood and less cells. So now we normally aim the needle directly to the darker spots, and you must not go to the very dark, because then maybe you go into 6 lesions that are sometimes within this type, when these are adenocarcinomas mucinous types. But you have to go into the hypoechogenic part. This would be better for sampling.
Rob, do you want to comment on how you target within the lesion?
Yeah. Well, this is, I was going to mention that this is my hope a little bit for both elastography and for contrast enhancement. I would love to see a technology that's easily applicable that would give me that, that read on where is it, where is it necrosis, where is it, and where is it tumor. And I think I don't think we have that yet. I think that what I do is I go a lot by feel now, Mike. And if an area of a tumor is soft, I tend to avoid that area. And if it's firm, I tend to go to it and spend my time in that. But I think the point is well taken. I think the idea to take home is basically we need to be looking at the tumor, feeling the tumor, and trying to go to the areas that are likely going to be yield tumor cells.
Rob, if you don't have a cytologist present, how many passes do you do?
Yeah, great question, Mike. And it's a good segue into some of your research. But I think the bottom line is there's a little bit of mixed message, but I think it's somewhere between 6 or 7 biopsies for a pancreatic lesion and probably about 4 passes for a lymph node to sort of get that maximum result that we want. But I would echo what you said. I think that we need to be striving for cytopathology in the room. And what I think that means for some of us is literally a specifically trained cytopathologist in the room. That's an unachievable goal in some areas of the world, Mike. And so that's why I think that the future is in teaching endosonographers to at least do enough cytopathology that they recognize what an adequate specimen is. Okay, so I've gone back and forth.
We're being notified that we are taking a break here very shortly. Do you have any final comments you want to make?
I don't, Mike. I think we'll take a look at what this biopsy shows. I think if this is negative and we're just not seeing anything at all, then I will reapproach that celiac artery. But I tend to believe that you're right, that this is a pancreatic head mass that has sort of crept along the celiac artery. Irregardless, if this turns out to be tumor, it's unresectable with the arterial invasion that we've demonstrated on EUS.